Then clinical examination. Normal gland is visible, not visible. Normal thyroid is not visible unless the gland is increased in size. If there is goiter only, it is visible. Otherwise, thyroid gland is not visible under the platysma. Instruct the patient to swallow and check for the gland mobility. If the lower limit of the swelling should be felt, if the lower limit is not felt, what does this mean? There is a swelling. If you are not able to feel the lower limit, what does this mean?
The gland is fixed.
Gland is
Fixed in one position.
Yeah, it may. If it is fixed, you will feel the lower pole, right? Lower limit is not felt, means it is going
downwards.
Yeah, downwards. What is that known as? Okay, keep this point aside. We'll discuss it. So this you keep in your mind. If the lower limit is not felt, that is the gland is going into the mediastinum. Okay. So any name for it?
Is it some sort of herniation?
No.
Like similar to that?
No. The gland is going beneath the sternum.
Retrosternal goiter.
Retrosternal goiter. Very good. So if you are not able to feel the lower limit of the thyroid, that means that it is having a retrosternal extension. See, the gland, before we go there, what is the extent of normal thyroid swelling? What is the extent? This is the sternum. This is the sternocleidomastoid, suprasternum, and this is the thyroid cartilage. Okay. So the thyroid gland extends between the sternocleidomastoid muscles, and it is 2 centimeters from the suprasternal notch. It is 2 inches, or 2 centimeters above the suprasternal notch. 2 centimeters above the suprasternal notch, and till the level of thyroid cartilage. This is the extent, right? Yes, no?
Yes, sir.
So if the lower limit is not palpable, that means that the gland is going downwards. So this means that the gland is having a retrosternal goiter, retrosternal extension. Okay? Clear? Very important. Just clinical examination, they will give you. If a 45-year-old female comes to the OPD, you are not able to feel the lower limit of the gland. The gland is, you are not able to feel it. It is going down into the retrosternal region. What is your diagnosis? Yes, no?
Yes, sir.
You understood or any difficulty?
Understood, sir.
Okay. So once inspection is over, then palpation. Always we'll stand behind the patient, not in front. We'll stand behind the patient and we will examine it from behind. This Pizillos method, just I have showed you Pizillos method, you know. This is the Pizillos. Patient will put the hands on the occiput and push the head against the occiput. Okay. So this is the Pizillos method. Clear, Pizillos?
Clear, sir.
Okay. And then uniform enlargement. The normal gland is there. It enlarges uniformly in physiological goiter. Physiological goiter is seen in where it is seen. Physiological goiter in who? In which age group? In which age group? Children or females? During?
At all.
Yeah, puberty. During puberty or attaining adolescence, there is physiological increase in the size because of to meet the demands. It increases in size. Physiological goiter, colloid goiter, Hashimoto's disease. There are uniform enlargement. Just the gland enlarges like that. Nodularity. Sometimes the gland has multiple nodules. It is varying levels of TSH stimulates it. Okay, so some part will be stimulated by TSH much, and some part will be much less stimulated. So in these parts there will be nodules. Isolated nodules are there. This is nodular goiter. And swelling lateral to the thyroid. Suppose this is thyroid, and if you feel something here or laterally, it may be an aberrant gland. It may be an aberrant gland or a lymph node from cancer. Okay.
So sorry to interrupt. I feel like it's a little fast if you're going.
Okay. I will go a little slow. So where from this is till this is it clear, or shall I repeat something for you?
Yeah, repeat the slide again, sir.
This slide only.
Yeah, please.
Okay. Yeah. Before this is clear, right? Physilos is clear.
Yes, sir.
Yes, sir.
Yeah. So physilos, just examine from back whether to make this prominent, to make the swelling prominent, we'll ask the patient to do this maneuver. Once this is done, swelling is obvious now. Swelling may be of 3 types. I am telling you. One, this is the normal gland. The gland may be uniformly enlarged, or the gland may be nodularly enlarged, or there may be swelling, and adjacent to the swelling there may be a small swelling again. So these are the 3 findings which we have on palpation. So uniformly enlarged, that means the patient has physiological goiter. Remember only one thing, no need to remember this: physiological goiter. Physiological goiter is seen in puberty. Why puberty? Because to meet the demands of the growing body, the gland enlarges. Okay, so in physiological goiter there is uniform enlargement. In nodularity, there are multiple nodules of different sizes. Okay, so suppose this is the gland, there are multiple nodules because of TSH. TSH will be stimulating it. Thyroid stimulating hormone will be stimulating the gland. Okay, so this thyroid stimulating hormone will have varied levels. Here it will stimulate less. Here if it stimulates more, so here there will be a nodule formation. So once when you palpate it, there will be multiple nodules. That is one thing. And finally, there is a swelling, and lateral to it there is a small swelling again. So these may be of 2 types. What is that? One is an aberrant gland. Aberrant gland. Aberrant gland means a small remnant of the normal gland, or it may be a metastasis from cancer thyroid. Okay, clear? These points are clear?
Yes, sir. So regarding the nodularity, can it be suggestive of nasopharyngeal cancer also?
Suggestive of
Nasopharyngeal carcinoma.
nodularity in the thyroid?
Yeah,
No.
nodularity outside, like the nodule.
No, it is nowhere related to that. It is different.
Okay, sir.
It's not related to that. And then still now we have seen only Physilos method. You'll never forget it, right? This image you should never forget. Physilos.
Yes, sir.
Okay. So Lahes is, remember, listen carefully. We stand in front of the patient. Suppose I want to examine the right side. 2 lobes of thyroid are there. It is also connected with an isthmus. So I want to examine the right side of the thyroid. So what I will do is I will push it. I will push the right side to the right side, and with the left hand I will palpate it. So same way for the left, what I will do is I will push it to the left, and with the right hand I will palpate. This is Lahes method. Okay.
Okay, sir.
Yeah. You cannot palpate both the sides at the same time. What will happen if you palpate both the sides at the same time? What is there here? Carotids are there. If you press both the carotids one single time, what will happen? The patient will go into syncopal attack. Okay, so it's always we have to examine each lobe first. So right lobe, push it, examine it. Left lobe, push it, examine it. Okay, that is the Lahes method. Clear, Lahes?
Yes, sir.
Then Kreil's method. Kreil's method is by using the thumb. We'll place the thumb to find any nodules or the thyroid. I told you nodules are there. So to just put the thumb here and just rotate it like this to identify any nodules or the thyroid. Kreil's method. To check for any nodularity. So only 3, nothing else. So just remember what is Physilos. This is Physilos. Lahes, push one side and palpate from one side. Push one side and palpate from the other side. Kreil's is
using the thumb to find nodules.
Using the thumb for nodularity. Only that. Okay. Eye signs, I think medicine, they will cover these eye signs. There are a lot of eye signs. Just there are no need of, not important also, just for completion. Von Grafe, Stelvag, Joffrey, Mobius. The different eye signs are there. It will be covered in detail in medicine also, in hyperthyroidism. So before we go into investigations, one thing I want, thyroid gland is there. Adjacent to the thyroid gland, a small swelling is there. What it might be? What are the two possibilities? Thyroid gland is there, and adjacent there is a small swelling again.
Abscess or
Any cyst?
Sorry,
Cyst.
cyst. Abscess or cyst.
Nodular.
Or
no, it
goiter.
may be an aberrant gland, right?
Yeah,
Just
aberrant gland.
it may be aberrant gland or a
lymph node.
lymph node from cancer. Okay, if it is adjacent to the thyroid, it may be an aberrant gland somewhere lying around, or it may be a lymph node. Okay,
Okay.
others also. Are you following?
Yes, sir.
Yeah.
Any difficulty or anything? Just let me know. Okay. What is Berry's ligament?
Posterior medial condensation of pretracheal fascia.
Very good. So that is the Berry's ligament. Okay. So thyroid, this is the basic things of thyroid anatomy and examination. Now we will go on to the investigations part. Investigations. What is TFT?
Thyroid function test.
Thyroid function test. So basically T3, T4, TSH. If TSH is increased, T4, T3 will be decreased. Then what is it known as?
Hypothyroidism.
Hypo. TSH is increased, hypo. Decreased TSH, T3, T4 increased, hyper. It is all under negative feedback mechanism. Okay, negative
Once
feedback.
more.
Thyroid stimulating hormone, T3, T4. So what is this? What I drew? What is this mechanism known as? What is this feedback mechanism?
Negative feedback.
Negative
Yeah, it is known
feedback
as
mechanism.
negative feedback. Okay. So once these increases, it negatively stimulates. TSH decreases. Once these decrease, again it negatively stimulates. TSH increases. So this is known as negative feedback mechanism. Okay. So this is about thyroid function test. We do only T3, T4, TSH in where we do free T3, free T4. Anybody? Free T3, free T4. Guess. Guess and tell.
Hashimoto.
In
No.
blood?
Sorry.
In blood?
In.
Blood.
Yeah, all these are done in blood only. T3, T4, everything is done in blood only. But specifically, where we do free T3 and free T4. Normally, T3, T4 are bound. They are bound to some protein, thyroglobulin and some protein. We do free T3, free T4, which is not bound to any protein. So remember,
Thyroid function
thyroid function.
to assess maybe.
Yeah, to assess thyroid function, we do T3, T4, TSH. But specifically, free values were in subclinical cases. What is the subclinical cases? Anybody?
Symptomatic patient.
Yeah, symptomatic. The patient is symptomatic. Okay. T3, T4, TSH are normal. Then we go for to identify any size minute variation. Then free T3, 4 are done. To identify subclinical cases, free T3 and T4 are done. Okay. Early, remember like this. In early disease, in established disease, T3, T4 are enough. In early diseases, free T3, T4 is required. Okay. If you have any doubt, we have to do that for confirmation. Clear?
Okay, sir.
Yeah. Then do an ultrasound again, imaging. Again, triple assessment, imaging, ultrasound. Ultrasound is done to look for gland enlargement, size of the gland increased or not, nodularity, vascularity, and lymph nodes. See, this is the gland. It increases in size. Okay, so whether the gland enlarged, increased or not, that is one. Any nodules are there or not? Two. Vascularity, how is the blood supply? Vascularity, that is three. And any lymph nodes, adjacent lymph nodes are there, that is four. Okay, these 4 points you have to know. Ultrasound is done to identify these 4 points. Okay. Yes, no?
Okay, sir.
Yeah. And we have a special investigation here known as thyroid scan. Thyroid scan is we give a colloid, we give it some substance IV, and the gland will take it up. If it is functioning actively, it will take up that substance. So when we need to do a thyroid scan, whenever the patient is having hyperthyroidism features, so hyperthyroidism, features of hyperthyroidism and low TSH, then we give the substance and we'll take a thyroid scan. I'll show you the images. And FNAC, what is FNAC? Morning we discussed.
Needle
Aspiration cytology. FNAC, if there is a swelling, we can just put a needle inside and we can aspirate it. Okay, so we call it as, there is a classification here, Bethesda classification. Bethesda classification of FNAC. Where else you have Bethesda classification? In gynecology you have one Bethesda classification. Where is it? That's also important, I think. In cervical cancer, I think there is a Bethesda classification. Yes, no?
Okay, sir.
Okay. So, in breast, FNAC cannot differentiate between. In breast, FNAC cannot differentiate between
In situ and invasive.
in situ and invasive lesions. In the same way, in the thyroid, FNAC cannot distinguish between adenoma and carcinoma, follicular adenoma and follicular carcinoma. Remember this point. In FNAC of thyroid, adenoma and carcinoma, follicular adenoma and carcinoma, they both look same. It cannot differentiate whether it is a benign thing or a malignant thing. That is the drawback. You'll remember 1 point in breast and 1 point in thyroid. Yes?
Okay, sir.
Yeah. So,
Sir, can you
once
repeat?
do, I'll repeat. Yeah, 1 minute. Drawbacks of FNAC. In breast, cannot differentiate between in situ and invasive lesion. In thyroid, you cannot differentiate between adenoma and carcinoma. Which adenoma, which carcinoma? Follicular adenoma and follicular carcinoma. Okay? Clear?
Yes, sir.
Okay. So, can anybody summarize till now what we have discussed in afternoon session, thyroid? Come on, no problem. Even there are mistakes, it's okay. What are the various methods?
We discussed the blood supply, the arterial supply of it. I don't remember all of it because I don't have them written down. But nerve supply, we have external laryngeal nerve and recurrent
Thyroid
laryngeal.
IMA artery.
And Behr's triangle is actually used to identify the recurrent laryngeal nerve.
Okay.
Behr's triangle includes common carotid artery, inferior thyroid artery, and recurrent laryngeal nerve. And the common site of injury of RLN is Barry's ligament. It is posterior medial condensation of pretracheal fascia.
Okay.
Then the ligation of arteries, we mentioned about superior thyroid artery. It is ligated close to the gland to prevent injury to the exterior laryngeal nerve.
Okay.
In the inferior thyroid artery is ligation of capsular branches to the gland to prevent devascularization of parathyroids. Then we discussed the clinical examination, which included inspection. So thyroid gland is normally not visible. In examination, we usually ask the patient to swallow and check for the gland mobility and the lower limit of swelling. And if the lower limit of swelling is not felt, it's usually retrosternal goiter.
Yeah.
And then we do the palpation method. We discuss the Pizillo's method. We discuss the Lahaye's method, Krell's method. And then palpation also we check for uniform. If there is uniform enlargement, then is the physiological goiter, colloid goiter, and Hashimoto's disease.
Okay.
Nodularity is isolated nodules of different sizes. That is nodular goiter. And swelling lateral to thyroid is usually either aberrant gland or lymph nodes because of cancer.
Okay. Good.
Then investigations. We also mentioned the eye signs, but you said that we will read about it in later.
Yeah.
So investigations would be TFTs. We will do T3, T4, TSH. If there is raised TSH and lower T3, T4, then it's hypothyroidism. Lower TSH and high T3, T4, then it's hyperthyroidism. In ultrasonography, another investigation that we usually look for gland enlargement, nodularity, vascularity, and lymph nodes.
Yeah.
And in hyperthyroidism, if we have, we usually do a thyroid scan. And fine needle aspirations, autopsy is usually done, cytology is usually done if we, that is also done if we suspect, and when it is usually done when it is bigger or we find it cystic, usually when is it done? That's another question I had.
Okay. So, what is the drawback of FNAC in breast cancer, breast lesions, and what is the drawback of FNAC in thyroid lesions?
So fine needle aspiration cytology in breast cancer, it is to differentiate. We cannot differentiate the in situ or invasive, and in case of thyroid, we cannot differentiate between follicular adenoma versus follicular carcinoma.
Very good. So this point is a golden point. You should remember it for life, I think, because multiple times you will be asked. And even people who take surgery also multiple times this will be asked. Okay. So Bethesda classification of FNAC, like same in Birad's, mammogram had a classification there. Birad's 1, 2, 3, 4, 5. In the same way here, thyroid 1, 2, 3, 4, 5, and additionally 1C is there. 1C is one cyst. Okay. So here it is non-diagnostic cyst, benign, follicular, suspicious of malignancy and malignancy. Same, almost the same. And what to do afterwards. If it is non-diagnostic, then do a repeat ultrasound guided FNAC. If it is benign, just follow up. If it is follicular, hemithyroidectomy, just remove half of the gland. If it is suspicious of malignancy, do a thyroidectomy surgery. Okay. So thyroid classification based on FNAC is having 6 categories in total. 1, 2, 3, 4, 5, and 1C. 1C is one cyst. Okay. So 2 is benign. 5 is malignant. Birad's 2 is
Benign.
Birad 1 is
Negative.
Birad's 5 is
Then it is
Malignant.
okay. In the same way, this also almost the same. And what to do if thyroid, if it comes, what to do? Just if thyroid 3 is there, follicular is there, hemithyroid, you have to do a hemithyroidectomy, because this cannot be differentiated. Whether it is adenoma or carcinoma, you cannot differentiate. So better to remove half of the gland. Others are suspicious of malignancy, you remove completely. Okay.
Okay.
Is this clear? Bethesda classification clear?
Yes, sir.
Okay. Then coming to the thyroid scan. I told you about thyroid scan. Suppose, why thyroid scan? See, this is the thyroid gland and the person is having increased T3, T4. Increased T3, T4. Okay. So, this increased T3, T4 may be of, listen carefully, it may be of 2 reasons. One is a nodule may be there and it only secretes T3, T4. The rest of the gland is normal. That is one case scenario. And whole of the gland has become toxic and it is secreting T3, T4 increased. T3, T4 is rising. This is another scenario. Am I clear? There are two possibilities. Yes, no?
Yes, sir.
Two possibilities in which the one could secrete T3, T4. How, sir? Again, please.
Yeah. See, a patient comes to us with thyrotoxic features. All features he is having, hyperthyroidism features he is having. So I will order a test for him. Thyroid function test I will order. Thyroid function test will show T3 and T4 will increase. TSH will decrease. Obvious, right? Then he comes to us. Then there are two possibilities, that his entire gland has become toxic and it is secreting T3, T4. Only a small nodule is there inside the gland which is become toxic and it is secreting T3, T4. Both are possible. Yes, no?
Yes, sir.
Yes, sir.
Yeah. So to differentiate between these two, we need a special test. So that is that thyroid scan. So we give technetium 99 or iodine 123. These are some elements which we give intravenously so that the thyroid takes it up. And
Sir, for iodine
whichever
131.
Sorry?
Iodine 131 for what, sir?
Iodine 131 is for different purpose. Iodine 131 for is ablation. It is to kill the cells it is used. I'll tell it, that is also there. We will discuss in next in the last session. Okay. These two are for diagnostic purpose only. Iodine 131 is for therapeutic purpose. It will kill the cells. If they are toxic cells, that treatment is known as, anybody? What is this?
Radical thyroid ablation. Radioactive.
Active, iodine ablation. Yeah, radioactive iodine ablation therapy. We call it as. That is iodine 131. That is different. Okay, we are not talking about ablation now. We are talking only in the diagnostic purpose. So we give this iodine 131, iodine 123 or technetium 99. Okay, and these type of scans will be there. See here. See here. See the first picture. What do you see here in the first picture? Just describe it. Whatever you know, you just describe it.
Thyroid
What are you
gland
seeing?
is seen.
Sorry?
The thyroid gland is seen,
Very good.
and it's clear on both the sides. The marginations are sort of.
Yeah, it is clear, but you see carefully. Here there is a small nodule which is not taking up the
The fluid which was injected.
yeah, the tracer. We call it as the tracer.
The tracer, yeah, sorry.
Okay.
Yeah.
The isotope, which it is not taking it. The
Yes, the isotope.
rest of the gland is taking it completely.
Yes.
This part is not taking. So we call it as a cold nodule. Cold nodule. It is not taking the tracer. Clear? So this
Yes,
is one.
sir. Clear.
See this picture, the second picture. This is the thyroid. Much of the tissue, much of the tracer is concentrated here only.
Yes, sir.
So this is a hot nodule. This is a hot nodule. Okay. So these two are wrong images. So just see this. This is a cold nodule. This is a hot nodule. Got it?
Got it, sir.
Yes, sir.
So cold nodule, the chance of malignancy is high, 20% chance of malignancy if there is a cold nodule on a thyroid scan. And hot nodule, that is a hyperfunctioning nodule, only 4% chance of getting malignancy in this. 20 and 4. Cold is 20, hot is 4. Okay?
What does a non-functioning nodule means? And hyperfunctioning, I didn't understand this part.
Yeah, I'll tell you. See, this is the thyroid. The gland is taking up tracer. Every part of the gland is taking up tracer except a small nodule. The rest, the tracer is there. In this, the tracer is not there. So this part is non-functioning, right?
Yes,
It's
sir.
non-functioning, so it is not taking up the tracer. If it is functioning, it should take the tracer, right? It is not taking the tracer. You can see here in this picture. See here, this nodule, it is become non-functioning. It is not taking any tracer. The tracer you give it IV, the thyroid gland pulls it up from the blood. It will accumulate in the thyroid.
Got
The
it.
rest of the gland is okay, but this part is not taking. So it is a non-functioning nodule. Non-functioning nodule. Okay. Whereas, see in this picture, the rest of the gland, the thyroid uptake is okay, but here it is more. The thyroid uptake is high here because it is hyperfunctioning. Yes.
Yes, sir.
Yes, sir.
So cold nodules are non-functioning nodules. The chance of malignancy is 20%. Hot nodules are hyperfunctioning nodules. They are not non-functioning. They are hyperfunctioning. They are increasing in their function. Hyperfunctioning nodule, and the chance of malignancy is 4%. Okay.
Okay,
So
sir.
different phrases are used in both the nodules.
No, same thing will be used.
Okay.
Because it is functioning, it is taking up. In cold nodule, it is not functioning, it is not taking up. That's all.
Okay, sir.
Okay.
So
Yeah.
different methods to assess the same thing.
Yeah, different methods to assess the same. Yes. No. One patient will have cold nodule. This is for one patient. This is for other patient.
Okay.
Same method
Okay.
for assessing different things, right?
Yeah, same method for identifying both cold nodules and hot nodules. Same method, but this will present in one patient and that will be present in one patient. Okay.
Okay, sir.
Okay.
Okay, sir.
And nodule. So come back again. There is a thyroid gland. The patient comes with T3, T4 increased. T3 increased, T4 increased. So what are the reasons I told you? 2 reasons.
Either there is a nodule or
Yeah,
the
nodule which
whole
is
of,
hyperfunctioning. Yes.
or is it possibly
whole
the whole
gland.
of a whole gland is involved?
Okay. If the whole gland is toxic, then it is known as Graves' disease. Graves' disease. Okay. If only one nodule is there, then it is known as Plummer's disease. Plummer's disease. Just remember these two. Okay. Whole nodule is increasing in function. T3, T4 is increasing. Then it is known as Graves' disease. Clear? If only one nodule is there, then it is Plummer's disease.
Yeah, got it.
Is it Plummer-Vincent's disease?
No. Plummer-Vincent's disease is different. That is
Okay.
siderophenic dysphagia. That is different. Okay, that is not the same. This is Plummer's nodule or Plummer's disease. This is only one nodule is there. It is hyperfunctioning. Hot nodule. That is Plummer's disease. Okay.
Okay, sir.
And the other thing is whole body iodine scan to check for. See, a patient has thyroid malignancy. You have removed the thyroid gland. So in future, to check for whether there is any recurrence or residual, you give a whole body radioiodine scan. That is a whole body scan. This is only till now we have done only in the thyroid region, thyroid scan. If you do it for the whole body, it is a whole body iodine scan. Same. You place the gamma camera only here. That is thyroid scan. If you place the gamma camera whole over the body, it is a whole body iodine scan. Okay.